there's not necessarily anything bad came out of it. You want to comment on anything?
I think it's just getting comfortable, really getting on the patient, getting your hands on them, and especially on the superior T4, if that right hand is tentative, you're not going to do anything.
Yeah. Tentative.
Yeah.
Yep.
You got to be.
I think we figured that out. Didn't we, Gail? We figured that out. Barbara was doing a good job, but kind of quite didn't know until she does it a few times exactly what its purpose is. You know, when you take a breath of air in, Barbara, when you take a breath of air in with the right side, you personally doing it, what's the right side when it fills up, Mike? What's it doing to the patient's right side? Filling up. Because when you fill up, you're using your air, your left diaphragm. Your left diaphragm was treating your patient's right side. Here it goes. Watch. Well, that's cool. I just used my left diaphragm to treat her right side. I know that sounds weird, but that's really what's going on. The only thing pulling that shoulder blade back is abdomen, zone of apposition, diaphragm. Isn't that cool to know? You're actually treating yourself when you treat the patient. I feel, Jen, when I'm sitting in this office working with you day in and day out, Paige, once in a while I just want to pop out of that chair and go find a patient to work on. I'll walk in a room, just say, you guys need any help with anything? Can I clean the windows? Do you follow me? Because I feel better, right, Jen? I feel better. I feel like I'm doing something with my thorax. I don't know how people sit all day long. I have no idea. I just don't get it. How do they do that, Jonathan? On page 47, you have that technique outlined for you, right? Everybody find page 47. What are we trying to do superiorly to this line that's parallel with the first rib in the front and the fourth thoracic vertebra in the back? Open it. Superiorly, we're trying to open it. And we're trying to isolate the left triangularis sterni upon exhalation. Remember, the sterni underneath your sternum is an exhaler. We're isolating that side. We're trying to get to move air out. We're trying to, see these I words? We're trying to inhibit the triangular sternum on the right side. That's why, Rick, I was telling the cameraman, keep taping that. That was awesome. A guy coming in telling another course attendee, Jonathan, keep that lateral border what? Down. For that reason. Because now you got inhalation, exhalation hand going on there. Inhibit the neck. When we do this, we shut the neck off. And I know we got neck people in the room that like to work with necks. I like to work with necks. Okay. Inhibit the neck's accessory means of respiratory activity. This morning, before lunch, we talked about the subclavius, the SCM, and the scalenes as muscles that like to overwork themselves to help you breathe, that all attach some way directly or indirectly to what? The neck. Integrate the diaphragm and the abdomen. At the end stage of exhalation, it wouldn't be the wrong thing to say, Stephanie, when you do that exhalation movement with that left hand, to say to that individual, tighten up your ab a little bit. Feel it. In other words, guys, think outside the box. Make it clinical. Gail, I'm going to bring you down here. I'm going to bring you down here. Now, hold that baby. Help me find it. Your hand's there. Maybe take your hand off. Tap it. Feel that. Hold it. Can you hold it there? Hold it there. Help me hold it there. Now breathe in. Oh, you let it go. Let's do it again. There's no technique in the book that says to do that. But why not do it? Because that's what we're going to do in the exercises that are about to come up. And then confirm with your patient, if you have a patient with a superior T4 syndrome, confirm it. Confirm that you've got that situation going on. In other words, after you do this, was there a change? Check it out. Did something happen? And make sure your patient recognizes it. Joy, make sure they knew it. They know it, and they will know it in the future. Oh, man, that's big stuff. Hey, Gail, you felt a little bit lightheaded, didn't you? Gail says, yeah, I feel a little lightheaded. By the way, I am on my left foot. Because she was neutral when we started. We just got more air on the right side. She's way over here right now. Whoa. Make sure they sense it. What's different? If they don't look for the answer, let them. I'm very, very bad at this. I try not to be biased, but I am. I assume that you're not symmetrical from the day one you were born. So they'll get up and they'll say, okay, which leg are you really feeling, right or left? And then I'll ask them, which leg do you really feel, right or left? And I'll see them standing directly on their right leg, and they'll tell me I feel my left. Now, wait a minute. Pick up your left leg. That's your right leg. Now, pick up your right leg. That's why you like your right leg. You fall. Now, stand there. Which leg do you really feel? My left leg. Because their left leg is their sensory leg. So until they feel their right leg is a sensory leg, even though they're standing on it, they don't understand what you just did. So there's got to be some outcome. Read anything about parafunctional habit training. They got to feel a reward. Did you feel a reward, Susan, after I worked with you a little bit?
Oh, yeah, I still do. And I stood on my left leg. I realized, oh my gosh, I'm on my
There's
left
a
leg.
there's a little reward. Isn't that a little reward?
He's been trying to get me for a long time to be on that left leg and stay here.
He's trying. Chris is great. But you understand he's trying, but your reward was you took a class, you understand it better, what he was trying to do. You're going to understand a little bit better Chris in the clinic, and now you know what to go for, and it's going to carry over, and it's no longer hopefully going to be a habit. So that's why. Make sure your patients understand it. They got to confirm. You got to say, do you really know what we just did for you? Let's take a moment, 5-10 minutes, and we're, I'm going to charge you for my time. I still think this is valuable time. Let's make sure you know what we just did. And let's maintain it. Let's keep it. Because you're just saving yourself future work, right, Kurt? I just knocked off 3 more sessions because you're going to carry that out right now. And I think that's a good thing to remember. We tried, right, Jen, to make this as easy as possible. So we put hair and eyes and smiley faces on. Jen's not too proud of the hair. I think she did fine. I have no hair, so I would be jealous. But she's got that hair on there, and that helps you understand that posterior head. And what we did is we said, there's that first rib. And from the anterior view, the airflow is not very sufficient in chamber 1. You see those arrows down on 1 and 3? And those arrows up on 2 and 4? That's 1/2. Why don't you write it on there? That's 1/2 of the gait cycle. That's 1/2 of the gait cycle. And then if you flip that little egg around, you have something different going on, sort of, in the back. So if you look at the left side, look at those arrows, Rick. Rick, there's not enough going on. What's not going on that left side?
Area.
Which is posterior mediastinum. So to get the left arrows to go up in the back, we've got to get the arrows to go down in the back on the right side. In other words, we want this to happen. We want this chamber to open up and this chamber to close. This chamber is open and you see right thoracic rib humps. Does that make sense to everybody? We want to get this chamber to come forward and this chamber to go what, everybody? Back. That's what that diagram is telling you. Air in, air out. Air's got to go into the posterior mediastinum and the other half of the gait cycle. And that would be the exact opposite of that view. Is that coming up? Yes. Okay, no, we don't have that view. So we just got to make sure, Jen, that they see the pattern, but we're trying to replicate that pattern alternately with the way you move. We're trying to get ribs to shift and what? Rotate. Okay, here's the problem. If you have superior T4 airflow on the right side, and I just did a right superior T4 technique to enhance that. We just did that, okay? Airflow on the right side just increased. You see box number 1. Airflow on the left side, on the other side, just decreased. Do you see box number 2? Do you see box number 3, how the airflow on the right side, over here, I decreased, and the airflow on the left side, okay, I increased. So basically, with a superior T4 airflow from the front and the back, you have a diagram that's showing you what's going on when you have a syndrome, after you try to get air on the right side, all the arrows on the right side should be going up. All the arrows on the left side should be going down. Look at the previous picture. See these arrows going down? If I reverse this, Jen, which they don't have in their manual, and I just did a superior T4 technique on you, and this arrow was going up, and that arrow was going up, and this arrow was going down, and that arrow was going down, we just made you an alternating human. Here I go. Here I go. I'm going to give you an alternating human. Airflow went on my left side all the way up. Arrows will be up on my left side. There they are. Arrows are down on my right side all the way down. If I stay there, that's called the right BC pattern. I take another step. Don't worry about the back right now. Only look at the front. I take another step. Oh, what are the arrows on the right side all got to do? Go up. What are all the arrows on the left side got to do? Go down. What if you happen to do this? What if you happen to do superior T4 syndrome? And we got a little problem. Arrow did go on the right side just like I wanted, above the fourth vertebrae, the first rib. But unfortunately, air is not following course below it or above that line like it should. In other words, apical expansion now is limited on the left side. I go back and I retest them. Hey, gosh, they got it. Air still can go on the right side. Got it. But now when I check the right side, Susan, they can't get air on the left. That's called the superior T4 syndrome. And Susan, you have it. We're going to show, Susan, we're going to show it to you. In other words, I just got air on the right side. Just got it over on the right side, Chad. And they're happy, got air on the right side. But she still can't get those lower ribs to work with those top ribs. She still can't figure out how to take a step, Chad, and get all the ribs to work together like this. Susan, it's real easy. Keep it simple. Keep it simple, you guys. I can't keep that air alternating back and forth. You have a superior T4 syndrome. What do you think is preventing this airflow from coming in on the left side? What do you think is preventing? Who's going to get the car today? Who's going to win this today? Think about the whole day. What's going to prevent airflow after you do a superior? I just opened it up. I just got air in that right chest. But the problem is they can get air in the right chest. Problem is now they can't get air in this left superior lobe over here. You took it away. Why is this rib over here internally rotated, 1 and 2, and this rib over here is externally rotated, preventing you from getting air in on the left side? Excuse me? Anybody, except the PRC people. Anybody. What do you think? Huh? You get the car! The subclavius on the what? Which side?
Right.
Very good. The subclavius on the right side will not let that right rib what? Internally rotate. Which means the rib on the left side is always in a state of what? You want to let it internally rotate. You want to let it go down. This rib is always in a state of what? External rotation. But here's the kicker. If this is being held up, and I can get air on the right side, and I can get air over here, and this one is also, this is internally rotated or externally rotated. Which one is it? I said it wrong. Which one is it? It's externally rotated. It's held up. I've got to get internal rotation on this side. This is externally rotated, internally rotated, with internal rotation on the entire side. And I've got to get internal rotation on this side and the entire side, and external rotation on this side and the entire side, and external rotation on this side and the entire side, as I walk. Everybody agree with me? But if I have the subclavius on the right side that's being held up, that's holding this rib from internal rotation on the right side, It's up. It cannot internally rotate. This rib then on the other